The broadcast is now starting. All attendees are in listen-only mode.
Hi everybody, and welcome to the National Hispanic and Latino ATTC's webinar. Today's webinar will be presented by Lieutenant Colonel Val Vincent Reyes, Military Liaison and Therapist at Del Alma Hospital Military and Veterans Program in Torrance, California. I will tell you more about him in a little bit. During today's webinar, all participants will be muted. The audio will be streamed through the computer, so please make sure that your computer and speakers are turned on and off to hear today's presentation. But first, I'm going to review a few housekeeping items with everyone. So if you notice that your viewer does not fit your screen, you can expand it by clicking the expand button, which is located in the top right corner indicated by the red arrow. Now you'll see that your viewer is expanded to fit the entire screen. Also, you can collapse the GoToWebinar toolbar on the right of your screen by clicking on the small red arrow to the left of the toolbar. And then click the arrow again and expand the toolbar again, and it will expand. As I mentioned, all participants will be muted as we move through the presentation. If you have a question for our presenter, we have a chat box that you can use. You simply type your question and hit send. We can pause for a presenter to address the question at an appropriate time during the webinar or again at the end of the presentation. A recording of today's webinar along with the PowerPoint slides will be available at our website www.attcnetwork.org/Hispanic Latino approximately a week from today. You can also find recordings and PowerPoint slides from all of our past webinars in the same URL. Also, one NADAC, one NBCC, and one ICNRC continuing education credit is available to those who attend today's live event. So if you're interested in obtaining CEUs from these organizations, please email us at hispaniclatino@uccaribe.edu. As I mentioned, today's webinar is sponsored by the National Hispanic and Latino ATTC. As of October 1st of 2012, the network has been restructured and now consists of 10 regional ATTCs, 4 national focus area ATTCs, along with the network coordinating office. As you can see by this map, the ATTC network regions were realigned to better fit the current HHS regions. And the 4 national focus areas ATTCs are listed on the left of the screen. Today's webinar is the 15th in a series that the National Hispanic and Latino has been offering. The network is funded by the Substance Abuse and Mental Health Services Administration and serves a critical role in improving the health of the United States. The network achieves this by translating, disseminating, and promoting the adoption and implementation of evidence-based clinical practices, and strives to improve the health and wellness of individuals whose lives have been impacted by substance use disorders. You can learn more about the network's products and programs by visiting the website. SAMHSA strives to reduce the impact of substance use and mental illness on America's communities through its programs and services, and demonstrates that behavioral health is essential to health, that prevention works, that treatment is effective, and people recover from mental and substance use disorders. And if you want to learn more about that, you can visit their website. So now I'm going to introduce our presenter. Lieutenant Colonel Reyes served in the U.S. Army for 24 years. He served his country with honor and distinction as a clinical social worker in Afghanistan, providing frontline behavioral health prevention, treatment, and stress control to soldiers and Afghan civilians. Lieutenant Colonel Reyes also worked with U.S. soldiers who were sexual assault survivors while in the military and served as a senior social work officer in the U.S. Army, working to install the first ever PTSD outpatient treatment program. After the devastating 4 Hood shootings in 2009, Lieutenant Colonel Reyes worked as a senior social work officer in charge of providing psychosocial assessments and screening on service members and civilian survivors. Upon retirement from the U.S. Army, Lieutenant Colonel Reyes was a clinical assistant professor at USC, where he helped develop the military social work concentration at the University of Southern California School of Social Work. He has also 23 years of experience as a parole agent specializing in parole mental health program development and street gang interventions, while also having 7 years of experience as a psychiatric social worker in inpatient psychiatric settings. Lieutenant Colonel Reyes was recently awarded the 2013 NASW California Chapter Social Worker of the Year, as well as the 2013 NASW Military Social Worker of the Year. He received his Master in Social Work from UCLA and his Bachelor from California State University, Dominguez Hills, and is a board-certified diplomate in clinical social work. He's an accomplished public speaker and has published several articles on military social work and PTSD. So, after learning a little bit more about our presenter, now we're going to do our poll questioning. So this is so that we can have an idea of who our audience is. We're going to do our questions now. And the first question: do you currently serve Hispanic and Latino populations with substance use disorders? And we have 100% of our audience says yes. We're going to go to our next question. Are you planning to serve Hispanic and Latino populations with substance use disorders in the next 6 months? And we have, again, 100% say yes. What is your current professional role? And we have 63% counselor therapist, 25% social worker, and 11% students. Which field of work do you represent? And we have 57% substance use, 29% mental health, and 13% policy and political affairs. Okay, good. And then, what type of setting do you currently work in? Okay, we have 57% substance use, 13% primary care unit, 13% managed care organization, and 25% university. And now we have our three questions. The cultural formulation interview, also the CFI, can be an important tool in the assessment of Hispanic veterans. Okay. And 100% of our participants say yes for that one. The next one. Family members should not be involved in the Hispanic veterans treatment because they may become affected by the information that is shared. And we have 100% say false. The last one, trauma may impact the belief system of a Hispanic veteran. And 100% say yes. Okay, good. So now, Mr. Reyes, I'm going to turn over the screen to you, okay, so that we can begin our presentation.
Thank you very much. Thank you very much, Dr. Orbish. Good afternoon, ladies and gentlemen. I wanted to welcome you to the National Hispanic and Latino ATTC webinar for this afternoon. And it's a pleasure working with all of you. And I want to give you the opportunity to understand the Latino and Hispanic veterans and active duty service members from the veteran and service members' point of view. I'm going to help you negotiate the mental health and behavioral health system for active duty service members and veterans, of which I'm honored to serve and to have helped and continue to do so. I want to make this as interactive as possible, and I wanted to invite you to, at any point, please ask questions, and then I think that Mr. Diaz and the technical staff will guide me through that process of answering your questions. So if you have in front of you, we're going to go through the next 50 minutes, 50 minutes, the PowerPoint entitled Social Work Clinical Skills Using Assisting Afghanistan and Combat Veterans, Cultural Considerations for Hispanic Veterans. So let's go to the slide number 2. And it's entitled Course Objectives. On the top, there are 3 course objectives that we want to discuss with you today. And number 1 is familiarization with the diagnostic skills used in assisting Hispanic veterans with post-traumatic stress syndrome. Number 2 is we want to learn to identify the PTSD cluster symptoms. There are 3 predominant ones. We call them the RAW symptoms, the acronym for re-experiencing intrusive memories. Second one is A for arousal or hyperarousal, and which is linked to their central nervous system. And then third is avoidance of people, places, and situations that remind them of the combat-related trauma. And then third, I'd like for us to be introduced to a couple of evidence-based practices, or what we call EBPs, that are currently being used in the treatment of combat-related PTSD. Next slide. It's entitled Rise in Hispanics in the Military, More Suffer from PTSD. So Hispanic service members and veterans have a long and very proud history of service to our country. The 2 primary reasons for joining the military, as you see on the screen, are a sense of patriotism and the opportunity to obtain a quality college education. What's significant in that slide, too, is that almost 40% of about a study that was taken by the Veterans Administration, 1.2 million Hispanic veterans, about 40% of them are suffering from symptoms of post-traumatic stress, which comparably is higher than the national rate for OIF, that's Operation Iraqi Freedom, Operation Enduring Freedom, Afghanistan veterans diagnosed with PTSD, and that figure is 25%. So about 1 out of 4 OIF, Iraq, and OEF, Afghanistan veterans are diagnosed with PTSD, compared to the sample study that the VA has of 40% of 1.2 million Hispanic veterans. Next slide. As you see on the slide, then, we have a proud history of Hispanic veterans in service to our country, incidentally and most interestingly dating back to the Revolutionary War. In 1779, General Bernardo Galvez led a group of Puerto Ricans, Cubans, to fight the British. And one unit in particular is the 65th Infantry Division out of Puerto Rico, which has a long storied history of serving in World War I, World War II, Korea, and then presently Operation Enduring Freedom. Operation Iraqi Freedom, excuse me. The 65th Infantry Division, interestingly enough, were nicknamed the Boricaniers. And it was commanded by, at that time during World War II, Lieutenant Juan Davila, who was the company commander of the 65th Infantry Division, which rallied to relieve the 442nd Combat Infantry Team, which was composed of all Japanese Americans who had been involved in rescuing the lost battalion. So we want to make all of us in the audience aware of the long history dating back to the Revolutionary War of patriotic service of our Hispanic veterans to our country. The next slide is entitled the Cultural Formation Interview, CFI. I want us to get the best promising practices for understanding our Hispanic veterans. So an important tool for our therapists and counselors to increase our understanding to helping Hispanic veterans is the Cultural Formation Interview, or the CFI, which is listed in the new DSM-5. And it has 4 particular domains that we need to look at as a template to help us therapists and counselors understand and treat the Hispanic veterans. And that's number 1. The first domain is the individual understanding. We want to do an assessment of the Hispanic veteran himself or herself and find out 3 milepost is, how does the individual perceive his or her problem to be related to combat or related to military lifestyle? Number 1 is, what kind of language does he or she use to express his discomfort or her distress related to the military trauma? The second one is, what is his or her ethnic background? And number 3 is, does he or she have any early family history of trauma? Because when we ask the question, do you have any early family history of trauma, then it might lead to us taking a look at possibly dealing with complex PTSD, which is layered levels of experiencing trauma. The second domain is we want to understand what are the families and the community's perception of his or her combat-related trauma and how he's dealing with it. So some of the questions that we as therapists might want to ask is, what does your family think is the problem? What does the community think is causing the problem? And what social supports are impinging upon or providing barriers to his or her recovery? When we talk about social supports, we're talking about school. Is he in school? Is he in vocational training? Is he at work? And are some of the combat-related traumas affecting his work or school performance? Next slide, it says on the top, the Cultural Formation Interview, CFI, of Hispanic veterans. We want to look at the aspects of a cultural identity that make the problem better or worse. The first question that we want to ask, it pertains to coping mechanisms, the individual's coping mechanisms, the person's ability to adapt and make decisions on how he or she wants to approach his or her difficulties. So the implications for us as therapists is, what did you do to cope with it? We want to also ask, what are the social barriers that make problems better or worse? What are the social factors that prevent you from getting help? For example, depending on where you live, is it discrimination? Is it, especially for Latinos that live in rural areas in the mainland, is lack of access to veteran services. And then number 4, the fourth domain, is what were the cultural networks of support? What kinds of help do you receive from your religion, your church, and the elderly adults that you respect as your mentors? And then lastly is we want to look at the clinician and patient relationship that you have with your veteran. For us as the therapist, we want to ask, and sometimes it's very difficult for us, but we want to ask consumer-related questions, is, do you have any concerns about the care that I'm providing for you? Do you have any questions for me? So if we take a look and in summary of the CFI cultural formation interviews, the 4 main domains, again in summary, are you want to get an individual or the veteran's understanding of what his problem is. Number 2 is we want to find out what the family and community's perceptions of his problems are. Number 3, we want to understand what his or her coping mechanisms are, how he or she is responding to cope with the military trauma. And number 4 is what were the cultural networks, what are the cultural networks of support that the Hispanic veteran has to help him or her. Let's move to the next slide. At the top it reads the Hispanic veteran and the role of Hispanic identity. There are 3 primary resiliency factors in the Hispanic cultural identity that impact treatment. The 3 main ones are strong family support, number 2, religion and spirituality, and number 3, language. The implication for us as therapists is that all of these 3, strong family support, religion and spirituality, and language, are interrelated and provide us providers with a holistic perspective which value makes the Hispanic veterans. And we need to ask ourselves, which one of those 3 does the veteran deem most important in his or her life that will provide him or her with the most resilience and resiliency skills. The next slide is strong family support. An essential component of the Latino culture is the family unit. Latinos place a great importance in the family, who not only provide material support, but a constant, reliable source of emotional support for its members. The implications for us as therapists is that there are 5 basic reactions to PTSD that the family demonstrates when the affected family member redeploys back to their home, and that is first one, negative feelings. The second one is avoidance. The third one is depression. These are all feelings and reactions that the family members show in response to the symptoms that the service member is showing to the family members, and we'll talk about those symptoms in the next couple of slides. And health problems. So again, there's negative feelings, avoidance, feelings of depression, feelings of anger and guilt, and health-related problems, because we find that especially a lot of Latino family members, they're so invested in helping, caring for the service member, their family member, that they forego a lot of the reward systems in order to help fully support emotionally and materially the readjustment process of their veterans back home. So as the implications for us as therapists and counselors is we might want to ask the patient, does he or she desire to have a family member or family members involved in his or her treatment? Because the family is such a strong source of support, we might want to include them in the family therapy or couples session. The next slide is spirituality and religion. Spirituality and religion is highly valued in Latino culture, especially Roman Catholicism. We found as combat therapists that combat trauma produces two reactions in veterans. First one is a positive increase in the faith or a negative decrease in the faith. But I found that many of my Hispanic veterans perceive that they have a more enhanced closeness with God. So we find that there's a relationship of trauma to spirituality, and we as therapists then want to explore the possibility of incorporating spiritual practice in such concepts as making amends or seeking forgiveness for their perceived personal transgressions against other human beings. Let's move on to the next slide. It's entitled Language, Cultural Definition of the Problem. The Spanish language has idioms of distress. For our Hispanic veterans, emotions are expressed somatically. The reason for this is in the combat zone, it's very acceptable for service members to report to sick call to the combat support hospital for pain relief or for pain management, because in the combat zone, for any veterans out here in the audience know that there's a lot of physicality involved in the combat zone. You're shooting weapons, you're carrying your backpacks, you're going on marches, you're running, you're fighting, for your life, and so there's a lot of physical pain that you have to endure. So it's readily acceptable to report to the sick call and talk to the physician's assistant or the surgeon and talk about your pain. So Hispanic veterans and all veterans are able to express their kind of emotions, and by pushing their emotions onto their bodies and seeking help from a medical provider in the combat zone for any pain, whether it's emotional or physical, that they have. Number two is the tradition of machismo, where in the service there is a strong sense of unit camaraderie, and no one, especially the Hispanic veteran, wants to show to their commanders or their battle buddies that they seem different from all the rest. So they'll go through the hardships, they'll go through the terror and not say anything because they don't want to let their battle buddies down. Most of all, they don't want to let their sense of pride down for the excellent combat training that they've received. So there's that unspoken sense of pride that they don't want to let themselves down with and disappoint themselves. So they hold that closely to their chest, and remains very silent about what they've done and what they've experienced. And then third is Spanish is the primary language when one wants to convey different emotions. So therefore, the implication for us as therapists is, what language would you like to speak to me with? What language are you comfortable in speaking? And if you're an English-speaking therapist predominantly, you might want to ask, well, how do you say that in English? What's the definition? Can you please define that word, that Spanish word that you used in English, so that I can better understand you? Okay. Let's move to the next slide. Asking for help and barriers is the title of that slide, and there are four. Their barriers, they include pride, loyalty, machismo, and gender roles. We want to juxtapose pride, loyalty, and machismo and gender roles, as barriers, because in the military, especially in the Army, they have what's called the military values, and in particular, we in the Army have Army values such as selfless service, loyalty to the unit, personal courage, the ability to endure physical hardships and put forth your best effort. Gender roles is a specific issue that's close to my heart too as well, because we find that the Latino veterans now are outnumbering the Latino male veterans 7% to 6%. So we see that trend to continue, where there's more Latino service members, but it takes its toll because in the Army specifically, it's a survival of the fittest. It's the biggest and the toughest person is the person at the top of the food chain. That means for the Latina service members, it means that she almost has to show a super masculinized profile, in that she has to do twice as hard as her male counterparts in order for her to be seen as a tough person. But then the difficulty lies in the redeployment when she comes back to Puerto Rico or her home. Well, she finds that now she has to give up her role as a combat warrior and has to readapt to her multiple roles as a provider, a caretaker, a significant other, and that provides many barriers for asking for help, because there's very few females that are veterans and very few people that she can kind of relate to. Next slide. Let's talk about treatment considerations for Hispanic veterans, the clinician-patient relationship. First of all, higher respect for authority. We want to help all of us therapists understand that we, therapists and counselors, are the frontline providers. We are the first caring and compassionate, helpful individual that our veterans will run into, because they're not going into the larger VA medical centers because they're living where they're living. Then there may not be one close by. So it is our responsibility to help our veteran coming back to readapt back to mainstream society. And it's a good fit for us because we provide that compassion and understanding and that credo, I will listen to you. And I think listening skills is the most important, but most of all, they treat medical professionals in the armed services with a lot of respect. And so that same dynamic they will carry back with them to their hometowns. So you'll already have a step up above professionally because they have a respect for medical and behavioral health professionals. In particular, the Army, they are taught to respect leadership and respect their chain of command. And by wearing the uniform, then it means that they respect their leadership and their medical and behavioral health professionals. So the job then is easier for us because we are there to help transition the veteran from using combat skills to learning adaptive community life skills. Number two is psychoeducation. We want to, the first thing that we know as therapists is to help give information to our client so that with the information the client can make more judicious and healthy decisions for herself. And as I said before, then psychoeducation is a way to kind of destigmatize PTS or any combat-related trauma by instead talking about life skills transitioning. So we're there to teach the person how to be a better citizen, how to be a better provider, how to be a better employee. In other words, we're going to kind of educate the person on how to transition all his warrior skills to successful life skills attainment. And then third is direct interventions. In particular, our evidence-based practice of cognitive behavioral therapy is a very structured course of therapy. And in the military, it's a very structured environment where they're trained using visual aids and writing their assignments down on paper. So by military training, they're used to everything that's structured and written on paper. So with cognitive behavioral therapy, it's a very manualized course, simple to follow, and it's very structured, so they will follow direct cognitive behavioral therapies. Next is we want to provide, again, because the family member is a source of emotional support, offer couples and family therapy so that we can help that veteran revitalize his or her relationship with his or her family. And then fifth, we want to ritualize treatments. Why? Because we Latino veterans place a great value on religion and spirituality, so you might want to integrate kind of religious practices in the homework assignments that you have with your veterans, especially with the issue of moral injury. Let's go to the next slide entitled PTS, Posttraumatic Stress Disorder, DSM-5. This is a new and improved version now, because post-traumatic stress has its own category now, and there are cluster symptoms that I want us to be aware of that are new here. And the first one is under A, direct experience. It says there, exposure to actual or threatened death, serious injury, or sexual violence. That's the difference now. Before, the DSM-4 did not have sexual violence, but because of the large numbers of military sexual trauma that's occurred in the military, they've included that terminology, sexual violence, in the cluster symptom A. What they've also included that's new is learning that the traumatic event occurred to a close family member or friend. Why? Because we found out that learning that a family member or a friend had experienced a traumatic situation leaves us with a secondary traumatization. Cluster symptom B, it lists intrusive recurrent memories. What these are contains of flashbacks. What's important to remember are, we call the flashbacks emotional flashbacks. It's being triggered by perhaps sight, sound, or smell of something that's associated with the traumatic event that the person associates with, and that flashback is a visual picture that the person sees in his or her mind that brings on an emotional overreaction, whether it's anger, an anxiety reaction, or feelings of sadness and depression. Let's continue again with DSM-5 definition of PTS. It says on the top, persistent avoidance of stimuli associated with a traumatic event. So they avoid people, places, or situations that's associated with a traumatic event. And then D, which is, again, the newest, is the negative alterations in cognitions and mood. So yes, for those of you who answered in the test earlier, does trauma change the self-concept? Yes, it does. Why? Is because we all maintain a belief system about ourselves, which is our I statements. I am a competent soldier, for example. It changes our belief systems about other people. They are dangerous, or the world. The world is a dangerous place. So this is specifically relevant to us as therapists because we can focus on cluster symptom D, the negative alterations in cognitions and mood, as our portal of entry so that we can cognitively restructure the distorted belief systems that are a result of experiencing that traumatic combat event. But we'll go through that in another slide, and I'll talk to you about what are those 5 belief systems that are impacted through military or even civilian-related trauma. Okay, it says on the the top there, again, this is the third slide that's related to the PTS definition in DSM-5, is marked alterations in arousal and reactivity associated with the traumatic event. So therefore it's listed irritable, behavioral, and angry outburst, reckless and self-destructive behavior. The reason for this is because our central nervous system then is what drives our survival behavior in the combat zone. Okay, is we have what's called the fight or flight symptom that's produced by the central nervous system, and therefore if the soldier is in the combat zone, let's say for 12 months, then you're basically on autopilot because you're constantly on vigilant alert to make sure that you can respond to a threat at any time. But the problem is when the service member comes back to the hometown, then the person does not shut off his central nervous system, right? And does not have time to decompress. Therefore, the person continues to be hyper alert, kind of vigilant at home, and that causes a lot of co-occurring disorders in the home life with relationships, which we'll talk about later. And then you have a duration of disturbance of 1 month or greater, and what's important is the significant disturbance caused by the cluster symptoms creates a disturbance in the social, occupational, or other areas of functioning in the community. And then the disturbance is not related to substance abuse. However, the substance abuse, alcohol, and illicit street drug use is a co-occurring disorder with PTS. And we'll talk about that too as well later on. So next slide, types of stressful combat zone or military setting experiences. You can read the slide there, and what's important to understand is there are many reasons why a service member is exposed to trauma, and the two predominant ones are, which is very, very devastating, is the IEDs, or what we call exposure to improvised explosive devices. Have you seen them on on the news reports? You've seen how they plant bombs on the road, and these bombs then are triggered by command detonated instruments like TV remote controls. And then the other one is what we call VBIDs, or vehicle-based improvised explosive devices, which are explosive devices that are planted in vehicles. So you'll have a soldier that's doing a road check and, you know, opening up the trunks of cars and getting imploded by an explosion. So that's the significant cause of injury in the war on terrorism in Iraq and Afghanistan, are those improvised implosive devices. Okay, next slide is there are 3 levels of treatment focus with Hispanic veterans that I want to mention you today. Is PTS, which is military related, or military lifestyle stress. Military related means it can happen in the combat zone, the trauma, or it could be experienced in garrison. You know, because when they're not in war, we're in garrison or we're on field training exercises. So when you're in garrison, it means that you're back at the military installation, and there's a lot of things that can happen in the military installation, like alcohol substance abuse, being a survivor of military sexual trauma. So we can use that term military related to talk about both what happens in the combat zone and in garrison. Number 2 is complex PTSD. A lot of service members come from disenfranchised, impoverished neighborhoods, and what's important is we feel very honored as therapists for the military because, you know, you'll find that the young person wants to join the military because he's finally decided in his life that he wants to be somebody and he wants to make a difference in the world and he wants to get a good education and he wants to support his family members and he wants respect. And so what he does, he finally comes to a point in his life where he wants to make somebody of himself and join the military. So we feel honored that we can get a young person or a person of any age with that sense of motivation to want to help himself, his family, and his country. But you'll find out that many of them then will come from impoverished backgrounds where they've been previously exposed to trauma, from early family history of trauma. So then at that point, you'll have clients that come in to see you, or veterans with complex PTSD, dual or multiple layers of trauma, that the implication for us as therapists is we need to ask our veterans to do a trauma timeline, is ask him from age 1 up to age, whatever his age is now, what kinds of trauma have you experienced and what age did you experience that with? Okay, so that you can help prioritize what your veteran wants to start talking about. Is, do you want to talk about early family history trauma in this session, or do you want to talk about your military-related trauma? But in the end, to increase positive self-esteem and decision-making process, you leave the decision up to the veteran as to where she wants to start at therapy. And then third, many Hispanic veterans suffer from moral injury. Moral injury is not a diagnosis, but it is a way to understand an emotional and a psychological construct by which they have transgressed their moral beliefs, and we'll talk about that in the next slide. So the three main treatment focuses with Hispanic veterans: military-related post-traumatic stress, complex PTSD with overlap from early family history of trauma, and then moral injury. Next slide, it says moral injury is a definition. Moral injury, it's a psychological construct in which the Hispanic veteran has a perception that he or she has transgressed his moral beliefs, whereas the primary emotion that he is having a difficulty dealing with is guilt or shame. Guilt or shame. And it's caused by several factors. Now, moral injury is that the first one is the war in Iraq and Afghanistan has also affected the civilian population. So the research study shows that a lot of post-traumatic stress is caused by the witnessing or the involvement of a service member in seeing a innocent civilian being hurt or killed by other military members. And the second cause of moral injury is receiving orders that lead to the death of either your friend or civilian. And third is giving orders which result in the death of civilians or innocent bystanders or your battle buddies. So there's three sources of this moral injury, and it has interconnectedness with our Hispanic veteran value of spirituality and religion, where they're taught to love and respect humankind, and when they receive orders to kill or maim innocent, well, consequently innocent civilians, then they feel that they've created a sin, or they've transgressed their moral beliefs. So what then do we do is we help that veteran deal with the guilt or shame. And we do that by creating a very safe and non-judgmental therapeutic environment where we allow exposure of that traumatic event that caused the guilt and shame, and we allow the reaction or the exposure or the talking out, and finally revealing the secret that he was involved in a very shameful event in war and allow that person to hear himself talk about that shameful event. And number two is we can also utilize what's called a promising practice of adaptive disclosure, in which you listen to the traumatic event that caused the guilt or shame, and then you create a opportunity to do a two-chair technique where you represent that person that the person hurt or killed, and you have a two-way conversation back and forth with the person that was hurt or lost or killed with the service member, and the service member is able to express sorrow and anguish and guilt towards that person that was killed or lost. So there's a lot of guilt therapy that's used with a moral injury. Next slide. Okay, let me explain the dynamics of trauma. Okay, let's say, for example, the traumatic event is combat related. So let's go into the mind now and emotions of a service member during a war situation. So let's say that the veteran now is on patrol, and he's in Afghanistan, and he's on a combat patrol, and he's going through a mountainous region where they know that there's intelligence reports say there's a lot of fighters that are waiting for them, but their job is to continue with that combat patrol. So suddenly he or she hears a bullet whiz by, and so what happens then is your soldier then is in full alert. So what he does is he hears, feels, understands, and records in his visual memory banks the moment that he saw the bullet hit the side of the mountain or the rock. Okay? And so he feels suddenly that he's about to die. So what he does then, he responds by ducking down, lying his flat on the ground, and taking cover so that the rest of the bullets that are shooting by, whizzing by, does not hit him. So what he does then, as a way to kind of psychologically adapt, when he survives that combat action then, his mind is like a moving picture camera. It records, and as a witness, everything that he heard, he saw, he felt, and he remembered saying to himself the precise moment that the bullet was flying past him, and he thought he was going to die. So let's say that they finish the patrol and they move back to their forward operating base, and he tries to get some sleep back in his rack in his tent. Well, as a way to psychologically adapt that horrific memory of being shot at by the bad guys was to replay those upsetting memories in his mind, because his mind is like a moving picture camera. So he replays those events over and over in his mind as a way to psychologically adapt to the trauma that he just witnessed and he thought he was going to die. So when he's trying to sleep, then he replays those events over and over in his mind. But then it's 3 o'clock in the morning, and suddenly he has impaired sleep, because then he's been replaying the events and he can't sleep because he has the same physiological reactions, is what? To stay alert so that he'll survive the moment that he was attacked. And then now he's physiologically aroused when he's supposed to be sleeping in bed at 3 o'clock in the morning. So that person then continues to replay those memories and is constantly kind of reminded of the day that he was almost killed, because then he's going to go back out the following day and go back out on another combat patrol, and he's going to remember that he was in that same hillside country, and that's where he was initially shot at the day before. So then he's going to be constantly re-triggered, and then he's going to be constantly on alert, and then thinking that he's going to be shot at again. So the soldier is unable to integrate those memories, and then he's going to be constantly hyper-aroused, and he's going to kind of have a difficulty healing from the wounds because he doesn't have anyone to talk to other than his battle buddies, and he's not going to talk to his battle buddies to say how scared he was. Okay? So the memories are not accepted as part of the past, and they're kind of suppressed in, within himself, in his heart, and he has to kind of live with those memories for the next 11 and a half months or until such time he's redeployed back to garrison or home. So just think of the trauma as preoccupation with those intrusive memories and replaying those upsetting memories, okay, and having the inability to kind of integrate those memories as he or she is reintegrating back to civilian life. Okay, the next slide is the belief systems that cause the cognitive distortions. And there are what we call the sticks. There are 5 of them. And this, my dear therapist, is the portal for entry for cognitive behavioral therapies or for counseling interventions, okay, is because soldiers or service members have this belief system in theirs that they have positive self-esteem, that they're trained to be a warrior. They have that warrior mentality. And so they go into the combat situation thinking that they are a warrior, and something bad happens. Because in war, some things happen, some things are bad. They don't go out the way that they're trained to react. So when they react in a way to the combat situation in which they feel that they let themselves down or somebody was hurt, then, or maybe they themselves were wounded, then that belief system in their sense of competence changes. So then they're no longer feeling that they are competent, but saying to themselves, I am now incompetent. And so that creates kind of the cognitive dissonance, okay? And that's the cognitive dissonance or the distortion in their belief system is, what do I believe I am? Am I a competent person versus am I an incompetent person? So that creates an internal struggle, that cognitive dissonance, and then they push their feelings of frustration onto their behaviors. So the behaviors are anger, irritability, participation in high-risk behaviors, self-destructive behaviors like drinking, fighting. Okay, so we can see then the sticks are our portal for therapy because we're going to help them kind of identify what their changed belief systems are. The first one is self-esteem. They have difficulty believing life is meaningful. Number 2, trust. STICS is the acronym for all of these: self-esteem, trust, intimacy, control, and competency and safety. Trust, difficulty in trusting one's decisions, others, leaders, governments. Third, I for intimacy. It questions the belief that people are capable of loving and worth relating to. Number 4, control and competency. Distorted beliefs that events are no longer orderly, predictable, fair, and controllable. And number 5, safety. A person's sense of safety and security is compromised. So as the implication for us as therapists then is, you'll see that all 5 of these then the service members will bring into the counseling session as having difficulty with, but I find predominantly there are 3 that they have the most problems with, and that's number 1 is feeling incompetent after experiencing a traumatic situation. So that's control and competency. Number 2 is safety. They no longer feel safe. And number 3 is trust. They feel that they cannot trust themselves or other people to survive. So the top 3 that you'll find in Hispanic veterans and most veterans will experience is cognitive dissonance in control, competency, safety, and trust. When it comes to co-occurring disorders or family relationship issues, you'll find that intimacy, a belief in one's ability to become intimate or re-intimate with their family members has been compromised as well. Okay, let's move to the cluster symptoms of PTSD. These are the behavioral symptoms that we need to do a clear assessment with. And one of the tools that I recommend that's an evidence-based practice is the PCLM. It is, you can find that on the National Center for PTSD, which is provided for by the Veterans Administration. The website is www.nc National Center for PTSD, that's ncptsd.va.gov, and they'll have a copy of the PCL. It's the evidence-based assessment tool to determine the level of intensity of these cluster symptoms that we talked about earlier under DSM-5, and that's the easier way for us as therapists to understand this is re-experiencing the trauma, R for replaying the intrusive memories, nightmares, and flashbacks, number 2, arousal, irritability, anger, and number 3, avoidance. So the questions that you might want to ask to kind of get a baseline, it's important for us to do 3 things. The tasks as therapists is, number 1, is ask questions about all 3, get the frequency, number 1, of all 3 of these. Number 2 is get the intensity, or how is it impacted your family, your work, or your education. And number 3 is what triggers these behavioral symptoms. So let's look at the first one, is re-experiencing the trauma. They take the form behaviorally of self-report mostly. So you have to ask your veteran, hey, can you tell me about your nightmares? Or when you're triggered, what kinds of memories does that bring up? Or when you have an anxiety reaction, what images come to your mind? Okay, so re-experiencing the traumas are mostly self-reported, so you need to ask this therapist questions about sleep, about daytime triggers, okay, and anxiety reactions. Number 2 is arousal, and these are behaviorally evident because in session the person will be irritable, hypervigilant, and he or she will show a lot of emotional overreactions or emotional reactivity. They take the form of irritability, anger, sleep problems, hypervigilance, startled reactions, and difficulty concentrating. What's really good as an assessment tool is when you have the spouse there or the significant other present, the spouse will report anger problems. They'll say he's having difficulty expressing his emotions because he will express his emotions in such a way that he'll overreact. So you might want to ask the spouse about how he or she controls his anger, because it might point to problems with domestic violence as well in the relationship. And then third, person avoids people, places, or situations or relationships that are associated with the traumatic event. So what's important to understand is what are the triggers that causes him. You might want to ask the therapist to avoid people or places, situations. And not to anger, to answer your pretest is avoidance then is shown behaviorally in alcohol and substance abuse issues. The person may drink too much or use too much because he does not want to deal with or talk about his or her own military-related trauma. You'll find that a lot of veterans will come back and push their feelings down into their bodies and use alcohol and substance abuse to kind of avoid talking about what they've witnessed because they fear traumatizing their family members. So they'd rather just use to continue to avoid dealing with their own feelings. Okay, intrapsychic factors contributing to PTS. What's important to remember is high-risk behaviors. We all come back with what we call combat operational stress. That is our DSM-5 equivalent of acute stress disorder, less than 30 days. you'll find that a lot of veterans will come back within the first 30 days. They'll have hypervigilance. They'll have numbing, and they'll be non-communicative. But it's not until they start to show high-risk behaviors or self-destructive behaviors that show that they might be a danger to themselves that might require some immediate attention from a professional therapist. And that's to ask questions such as therapist would be, have you thought about hurting yourself? Have you been so depressed that you feel like killing yourself? So the military places a high value on direct communication. So as therapists then, it's good for us to be direct and ask questions straightforward, such as, do you feel like hurting yourself? Have you had thoughts to hurt yourself lately? Have you felt so upset and sad that you felt like hurting yourself or other people? So please do a risk assessment when you see your veteran to rule out any suicide ideations or high-risk behaviors. Okay, let's talk about co-occurring disorders and psychosocial issues. The two prominent co-occurring disorders that we want to focus on is, again, alcohol and substance abuse problems because of the numbing and avoidance that we talked about symptoms. They would much rather stay to themselves and isolate and use or drink because the service member comes back with multiple uncomfortable feelings, and it's very difficult to sort out those feelings, but it's much more I guess risk-free not to talk about those problems because he's suffering or she's suffering from so many different feelings that brings great discomfort. So we might want to do an assessment for substance abuse at that first session too as well, and ask the frequency of use. Number one is what triggers him to use, what family members or what does the family member say, or what happens in work that brings about the urge to use. Okay, so we want to kind of take a look at the frequency and the triggers and ask the client, well, what other ways have you been doing besides using that you've been doing to help you cope with your feelings? And number two is we find that there's a lot of marital conflict and relationship issues. So when we talk about the three main sources, the two main sources of co-occurring disorders, then it's the sources are trauma in combat, but the numbing and the avoidance cluster symptoms bring upon family relationship problems because the person doesn't want to traumatize her family members. The person then wants to kind of protect his family because he values family relationship to the point that he kind of ends up isolating himself because he fears that he will traumatize himself by talking about it and traumatize his family members, which will hurt him or her most of all. And then second, he'll use as a way and use alcohol or substance abuse as a way to kind of numb out those feelings and not having to deal with the family members, but kind of still stay kind of still stay kind of isolated to himself and deal with the problem by himself. So as a therapist, then, we have to look at isolation as a symptom that we have to reduce and increase his or her ability to kind of socialize and become re-engaged with the family members. Next slide is primary life areas of functioning. Take a look at those bullet points, but the most important is the veteran adjusts through three main life domains back into mainstream society, which we as therapists will need to focus our treatment plan on. And that's number one is all the veterans want to readjust back and re-engage with their family members. Number two is the veteran wants to get a productive job or wants to return to a productive job to support himself or herself and her family members. And number three is the veteran wants to take advantage of the post-9/11 new GI Bill and get a good college education or get vocational training. So you'll find that a lot of the social dysfunctions will be centered around family relationships. Number two, employment and return to work issues. And number three is difficulty dealing with PTSD symptoms in school or in vocational training. So we as therapists want to ask questions about how he or she is doing in all three spheres. How are you doing with the family? How are you doing at your employer? And how are you faring well in school? Next slide is evidence-based practice and non-traditional healing practices for PTSD. Here's a whole list of evidence-based practices, but the most important that I wanted to talk to you about is the Department of Defense approved evidence-based practices, and there are three of them. Two of them are listed on the left-hand side. Cognitive processing therapy, which is found effective for specifically military sexual trauma. Number two, the DoD-approved evidence-based practice is prolonged exposure that we have here. And then the third is trauma-focused cognitive behavioral therapy. Number four bullet there is family-focused therapy. That's what we use a lot then. That's a very promising practice is trauma-focused family therapy, where they openly discuss the trauma that the service member has been through, and the family is engaged in helping to listen and understand the trauma that he went with, and teaching relationship skills such as improving communication, family problem-solving skills, family re-engagement skills, and lastly, parenting skills. And there's other types of non-traditional healing practices like fitness training, you see there, and a big now source of focus for community providers is teaching resiliency skills. As you know, some of the resiliency skills we have as therapists is teaching assertive communication, problem-solving skills, stress management skills, anger management skills. Those are resiliency skills that help our veterans kind of readjust back and be a more successful civilian and a more happier family member. A complementary and alternative medicine that you see up there is in the forefront too, because we have what's called EEG neurofeedback. Neurofeedback is now listed as a complementary alternative medicine for treating service members. They have the Marines specifically have a neurofeedback program, and we in the hospital at Dalamo Hospital are starting a neurofeedback program very shortly as well for active duty service members. Okay, let's talk about the theoretical basis for understanding PTSD. We as therapists need to understand that our client, our veteran, has a pre-trauma belief systems of himself, herself, and the world. Okay, those are known as, you know, positive self-statements like I am a good person, I am good, I am competent, and the world is a safe place, the world is a good place. Okay, well, what happens then is the person goes into combat, and then he experiences a traumatic event. So there's three things as therapists that we need to kind of identify in the exposure of the traumatic event. So when you're in the session as therapist, you want to ask the question, tell me in your own words what you experienced during that traumatic day that brought you a lot of fear for your life. And there's usually three elements that the veteran will explain to you she has just experienced. The first element is stimulus elements. We talked about that earlier in the dynamics of the person being shot at. The person in the middle of a traumatic experience then hears, sees, and feels all the associations, okay, that he or she remembers that are related to the moment that he almost thought he was going to die. So some of the stimulus elements might be the hearing, the sound of a bullet flying by, or the smelling of gasoline, you know. For example, I had a Hispanic veteran that I was counseling in therapy that told me that one of the triggers, one of the stimulus elements that he had was a civilian riding on a bicycle next to their convoy of vehicles, because he remembers seeing somebody from another military vehicle shooting at the person riding the bicycle. So for him, one of his stimulus elements was seeing anybody on a bicycle, because it reminded him of the day that he saw a person that was shot in front of his eyes riding a bicycle. So for him, that's his stimulus element, or that's his or her trigger. So for us as therapists, we need to ask questions about what triggers your emotions and what did you hear, see, or feel at the time you experienced the trauma. And next is response elements. The response elements is how did your veteran survive, or what did he do initially? And that's related to the fight or flight response. What did he do to survive the traumatic event? And that's the response elements. The question you can ask as a therapist is, how did you respond the moment that you saw that you were being shot at? Oh, I fired my weapon back, or I ran for cover. And this response element is important to understand, because sometimes the veteran, in a way to protect or to run for his life, runs actually from the battlefield without firing his weapon. So what does that mean for you as a therapist is you'll be dealing with the person's sense of guilt that he did not fire his weapon, and that his initial response to protect himself was to flee, to run. He'll feel guilty, but your job is to be non-judgmental and just be accepting and be understanding. That's the way that he decided to survive that day. And number third is meaning elements. We want to ask the questions of the client, of our veteran, what did it mean to you? This is an important entryway into therapy, because we all find meanings in our traumatic events. We all, as a way for us to psychologically survive, assign a purpose and meaning for the reason why we survived a traumatic experience. Oh, I was able to survive because God helped me through it, and that means that I'm going to be a better Christian or a better Catholic. So you might want to ask the client, what did it mean to you that you survived this traumatic event? Or what do you tell yourself, or what do you think about yourself if you're a cognitive behavioral therapist? What did you think about yourself the moment that you survived that traumatic experience? Oh, I thought I was going to die. I thought that my life was going to end. That was the meaning for me that moment. Okay? So you might want to ask that question, what did you feel and what did you think the moment that you experienced that traumatic situation? And then third, most important, is how did others react to you the moment that you came home? Because a lot of veterans, especially Vietnam veterans, will remember that they were not traumatized so much by what they experienced in Vietnam, but I'll have Vietnam veterans tell me that it was the way they were treated by the hometown people that made them feel that they were outsiders, that made them feel very resentful. So you want to ask, well, what kind of reception did you get from your family when you came home? Because the reception by the community and family is very important in how they feel and think about themselves and how they find meaning in their war experiences. Okay? So the two negative schemas, or two negative belief systems that underlie their kind of high-risk behaviors or unhealthy behaviors that they participate in is get an idea cognitively of how they think about themselves, I am inept or I am incompetent, and how they think or what they think of the world. The world is a dangerous place. Because then if you get those two underlying schemas, those negative schemas of negative self-esteem and negative perception in the world, that will be your source of schemas to cognitively restructure in cognitive behavioral therapy. You'll help them identify that they feel inept, and then you'll replace that thought with a more healthier thought that, yes, I am competent, and sometimes I'll experience situations that are challenging to me, but I can adapt and overcome. Okay, so it's in cognitive restructuring, we will replace those negative schemas of self and the world and replace it with more healthier thoughts about the self and thoughts about the world. Dr. how are we doing time-wise?
We should be
Okay,
finishing. Well, we don't have enough time left.
Okay, how much time do we have left?
3 minutes.
Okay, so I'll go through the slides. We have like 5 more, so I'll just go through those real quickly, okay?
Okay, thank you.
Thank you.
Okay.
So the next one is clinical assumptions. What we want to think about as clinicians is suffering from PTSD is, for the Hispanic veterans, involves betrayal of spiritual, moral, cultural, and family values. When you help your Hispanic veteran heal from PTSD, we want to deal with the cognitive dissonance. Am I competent versus am I incompetent? And help them resolve that so that they'll cognitively restructure and come up with a more healthier self-statement like I am competent. Clinicians can assist the veteran to process the guilt and shame. Next, there's need for giving a homework assignment that includes making amends or asking for forgiveness from the aggrieved person. And then you want to involve the Hispanic veteran with social support from the spiritual, the cultural, and family. Next slide. The importance of trauma-focused psychotherapy, such as cognitive processing therapy, is 4 of them. You do the exposure. You expose the traumatic event. Number 2, you cognitively restructure the distorted belief systems about the self and the world. Then you stabilize by providing relaxation techniques, because remember, the person is very hyper, so you want to reduce the hyperactivity by teaching calming techniques, so teach stress relaxation therapies and life skills, and then psychoeducation on the course of therapy on talking about transitioning warrior skills to positive life skills. Again, this is another summary. The next slide. The goal of treatment is to help the person learn skills that will reduce the overall arousal. Number 2, for the unhealthy behaviors, help them identify the healthy behavior and help them develop more positive, healthier behavioral responses. So if the person is anxious, teach anxiety reduction skills, teach assertive communication skills, so the person will be more pro-social and healthier in his responses. And then for negative thoughts and belief, replace negative thoughts with more positive thoughts. And here's the slide. You can go with this slide more. These are the great icebreaker questions so that you will be military competent and you will provide more compassionate engagement and develop trust with your Hispanic veterans. Ask questions: what branch you were, what was your rank, what unit was your service member assigned to, where did he serve, and what was the service member's military occupational specialty. And most important, please provide compassion and empathy for your Hispanic veteran. It's very, very important to convey the thought that I will listen, because you're an open-minded and non-judgmental and very effective and caring therapist and counselor. Most of all, provide active listening and hear in a non-judgmental fashion what he or she has experienced. They all want someone to care and listen to them, and you are that first friendly face to do so with your compassion. And these are the screening tools that I talked about earlier, the PTSD checklist, the PCLM. M stands for military. They also have one, PCLC, for civilian trauma, so you can do assessment of the raw cluster symptoms as well for civilian-related trauma. The Beck Deficient Inventory, the Novaco Anger Scale, and Assessment for Suicide Scale. You can find the PCLM in the www.ncptsd.va.gov website. Subject to your questions, that's all that we have for this presentation. Thank you for listening. I'll open up questions to the audience.
Thank you, Mr. Reyes. Unfortunately, we're not going to have enough time for our questions, but what we're going to do is that we can, I'm going to send you the questions that we have so far, and then you can answer them in a Word document, and we'll include them with the recording of the webinar and the PowerPoint presentation.
Sounds good.
Good? Okay, perfect. We have a few questions, so I'll send them to you soon so that we can include them with our recording. Okay, so I just wanna thank you again for sharing your experience with us. I think it's very valuable, and from the comments that we've received, people seem it's been very interesting, and people have learned a lot on becoming more military competent. So I'd like to remind everyone that a recording of today's webinar and PowerPoint slides will be posted and available at www.attcnetwork.org/Hispanic and Latino. And this concludes our webinar today. And again, thank you, Mr. Reyes, Lieutenant Colonel Mr. Reyes. We look forward to collaborating with you on a future occasion. Remember, for our audience, to look at our website to learn about future webinar, and as you leave today's webinar, you'll be directed to complete a brief survey about your experience. Your feedback is very important to us, and we appreciate you taking the time to tell us what you thought of today's webinar. So thank you, everybody, and have a great day.
Thank you, everyone.
Thank you.